this is the final section, but very important for the 2 days workshop. And now we invited the 5 speakers within the 2 days. They give us a very good talk about the different countries, different strategy and cases being project. And right now we are open for the floor. If any question you want to know, you can ask our 4 and 5 experts. And before you can think about the question. And before any question from the floor, I will put on one common question for our 5 experts. You know, around 2020 to 2023, we are facing a very challenge of the COVID. And the COVID, they are very, they in the most countries, especially in Taiwan, we look at the cancer screen rate, they are increased. And after the COVID pandemic, in Taiwan, you can see from our the refugee wave, we see the colon cancer, they are rebound for the mortality. So in the different countries, you facing this very global pandemic, any strategy, any solution during that time, you want you have take in order to prevent maybe you will facing around in the future, you will maybe 3 to 5 years, you might rebound on the best. Okay, so I will ask any suggestion or any solution, maybe from the pen. Yeah.
That's well, it's a very difficult question. So during the COVID period, it's the screen rate went down, and it doesn't come back to the level yet at the national, at the most recent statistics. So we're trying very hard to educate the public to come to the screens. Well, it wasn't high to begin with. It's 40%, but now it's 40%, and I don't know. Well, we're trying very hard to educate people. We are trying to, whether or not the COVID was there, we try very hard to invite the residents, but at the moment, I don't see the success yet. But we keep trying.
Program is very similar than a long pandemic period. So nowadays we expand the use of digital healthcare. So at the time we have a pilot. The remote consultation can help the people to remain here or stay here. So we can use the digital skill and expand it. And another one is the earlier I mentioned use AI. So the next generation can use AI and digital skill system. Thank you.
In Singapore, we had a little different, we took a different approach, I would say, in that we deliberately actually stopped services. In Singapore, we have essential and the non-essential services. So because of the COVID impact, we had to actually redeploy most of our healthcare and manpower, including giving people from health promotion board. We don't do clinical services, but even we were actually redeployed to looking at supporting the COVID operations task force was formed, and we went into that. So during this period, we did have something called suspension of the non-essential services, and all the screening services fell under that. The only exemption given was for those who had screened if they needed post-screening follow-up at the hospitals, irrespective of whichever cancer screening it was. We asked them and we brought them into the hospitals, but otherwise everyone was actually deterred, barred from entering the hospital because again, the concern was very much about infection, and also within the population also the awareness was pretty high. People didn't want to go into the healthcare setting, even they didn't even want to go to the GP setting, GP clinics or polyclinics anywhere, they were keeping away from it. So it was intentional for the first, I would say 6 to 8 months, initially where we didn't start. But when we resumed services, it was like how travel, when we are back, right? There was something called revenge travel. So screening quickly, there was also a kind of a loss. And people suddenly just all wanted to come for screening, and we had a huge surge which we saw. And the challenge is screening service is not a problem for us because, like what I shared yesterday, we have quite a good screening distribution. We have 1,400 GP clinics, we have a lot of polyclinics. The challenge again for cancer screening is once they picked up the positive, the referral load, which went to the hospitals, that became a big challenge, which is something we have to work with. If we had to do something differently in the future, 2 or 3 things I can think of similar to what Dr. Osh shared. One area which we looked at during the COVID is telemedicine, video consults, which is something not thought of. Singapore has now adopted it, and we are now looking at regulations and certain guidelines for it. Number 1. Number 2 would be use of like kiosks. For example, but during the COVID, we had like kiosks where you can go and just scan your IC, your identity card, and you can pick up masks. You can pick up your ART kits, etc. The PCR kits can be picked up, PCRs or ART kits. All these were given by the government free, so you can pick up. So one of the proposals which we discussed with one of our vendors, we're still discussing to see whether these kiosks can actually distribute the kits. Don't need to go to the GP clinic to pick it up. We're also looking at similar things for our cervical cancer testing, where HPV also, besides the physician sampling, we're now looking at such sampling, where we're looking at doing that similar. So these are things which we're looking at, and last but not least, of course, we're looking at digital and AI.
Very similar to the country with the COVID, common way of cancer screening. What we have done during the period of COVID pandemic was to apply the so this is actually the first trial with the COVID administration. So yesterday I have shown that the detecting or diagnosing cancer or larger increase along this concentration. So what we have done with the pandemic was to repeatedly, very intensively invite those with very high concentration to come to local So in this way, for example, in University Hospital, we only perform 60% of the total number of the pandemic compared with the pandemic. However, we detected a similar number of basic cancer within this period. So I think we should learn from the pandemic. We can do better. And it is very likely that we will encounter another pandemic, especially that now we have a global warming. So some virus that human beings never encountered previously may appear in the future. So firstly, I think we have to confront the cancer screening system with resilience. So, and then nextly, we need to improve the speed of available data from cancer registry. So in Taiwan, we usually have a 2 to 3 year gap of cancer registry. It is okay without pandemic, but when we have pandemic, we need a very effective feedback from the cancer registry. For example, during the pandemic, many people are very happy about the decline for cancer incidence and the increasing instance of lung of course, increasing in lung cancer is not a good thing. But this is actually caused by the increasing use of chest CT during the pandemic, and the decreasing number of colorectal cancer is caused by the cease of activity. So this is not a good thing. And also we observe the increase in the percentage of advanced. So this can forecast the future increase in future increase in advanced cancer and the increase in colorectal cancer death. So probably we need 5 years to get this done, but I think we need to learn the lesson.
Thank you for the first expert response. I think this is really keep in mind because the emerging disease will become, when they will come, we don't know, but we should prepare. Yeah, okay. And the second question is, I follow the Professor Shou's reason. She mentioned the method of the AI assist to improve the cancer screening rate, also for have a good awareness. But AI assist needs a very good data bank. So, do you have any kind of idea to increase or to prefer the data quality of the nationwide for the future to develop the AI assist the cancer screening program? Any idea? Because most of the countries, their IT technology quite high compared with the other countries in Asia. So do you have any prepare any program to improve or to collect more data, good quality, and then you have good AI or LLM method to persuade our participants to do the good smart precision screening program. Any types of very humble can
Yeah, I think, in my opinion, before talking about AI, I think we need a digital transformation of the government and the database. So without a digital transformation, then we don't have any kind of data to use. And the secondary, some people may say, even if we don't have a structured database, we can use the natural language or other AI technique to deal with. But however, the accuracy comparing structured database and the AI and using the natural language is inferior to the complete digital transformation and using the AI technology. So that's say we need to work on digital transformation, not only the numeric data, but also all the imaging, including mammography, endoscopy images, and the chest CT images. So these are two meanings. The first one is we can have a more comprehensive data to be analyzed. And the second thing is that we can also use this digital database to develop healthcare industry, including some new AI technology for cancer screening, or some, if we have a biodeposit of the biospecimen, we can also develop useful biomarker from our cancer screening program. So this is my expectation for cancer screening 2.0 for Taiwan. But I think this needs the effort of every aspect and every sector.
Any solution or any future plan about this issue?
Sure, to confess, I'm not the expert here, and we are very much in early stages, but similar to what Chu was mentioning, for us, for AI or anything to do with the next level of precision medicine, I think the basic, very key is AI. And as I shared, one of the major challenges for us today is IT. So the infrastructure is still in different levels of readiness and what we call. And we have very many players with different IT systems. So the data actually has to all merge together to make sense of what we're talking about. There is a great effort at the moment under the ministry to bring all the data together, but still, it's by and large still at the public sector level. We have a major section which is happening at the private sector, which is not coming into the government database. That is a major challenge. And what Dr. Kashi was also mentioning, the survey data is one thing, but the actual service data is something really different. That's another challenge we have. So I think once we start getting this together, similar to what we have in cancer registry, where whether it's public or private, we have a law which actually asks for all the data to be compliant. So we have something like that, which is our ministry is working on some kind of bill at the moment. So once we have the health info bill which is enacted, hopefully we'll get this data in and we can start looking at some form this precision planning and precision medicine as we move forward. The area we currently are working on within the national program is for mammography. We started looking at AI-assisted mammography, wherein because we really have a data of our radiologists and the screening numbers are going up. We have a double read program, which means there are 2 leaders and there's a discordance of 2 leaders. We have a third radiologist who has to come in and give their final opinion. So which means it's quite cumbersome from a radiology point of view, and our manpower is pretty short. So that's that's one of the key areas we're working on currently. We are starting a pilot in Chad and looking forward to it.
Yeah.
Yes, I'm expert in this issue, but I think the main is the data quality and quantity. So our government, we have a pilot program, has regulatory. So some people give idea about personal health data. So they data entered one hospital can use other hospital. So if the data is provided many things, so the amount of data increases, the diagnosis is more accurate and data trusted. So the pilot test is started last year. So when the success the pilot test, we can use people's health data any hospital, and people can access any hospital data. Thank you.
Yes, in Japan, we have the government is trying very hard to link the data, including the administrative claims data and cancer registry data and so on. So it's coming, and but it's not there yet. And we have to have those kind of good data to feed the AI system to learn and create a good system. And that's thing to come, I hope, in a few years. And it comes to me that, well, it's the data quality, accuracy, quality was very much emphasized traditionally. But I thought that, in this AI era, maybe it doesn't matter a lot. AI is not quite accurate at the moment in any way. So they may be able to learn from somewhat dirty data, but we need to be quick and update so that it can be relevant to the real world. So maybe we may need a switch of our mindset from the accuracy to the quantity or speed of the data. That's my personal thought. It's not every Japanese would agree to that. I thought like this.
It's the role to precise cancer screening. Okay, so maybe we need more empirical study. And for the government, for the official, we have the national budget. So if we can use the precise industry data, maybe it's effectively for our government. It's good for us, but maybe we can have more studies without to support the public.
So the partner choose a suggestion to different countries.
Yeah, okay. Thank you, the Director Cho proposed really two key questions, particularly for COVID-19. It reminds me to go back to the 2023 question. Yeah, and also I think the AI. But I think before addressing two key issues, I would like to feedback to the countries who present here from my viewpoint. First of all, I think Singapore is very gorgeous to propose. I call the systematical and integrated multi-stakeholders, multi-discipline systems for the cancer screening. I can feel that. Particularly, you have amazing about the regional health managers, which is very difficult for us. Even not only in Taiwan, I think even in other Asian countries. You know, you want to develop a regional health manager to cover all the stakeholders. For me, it's a challenging job. So this is one thing I think for Singapore, I believe. And the second, particularly I think is propose a very advanced program about prevention and surveillance based on the big data systems. I can also see your ambitions. I think it's correct. That's why related to the second question, Professor Cho just asked us. I mean, because you mentioned about actually is exactly we are talking about the 4P medicine, cancer screening. You know, particular for I'm a person been devoted cancer screening over 3 decades. I think participation is always our job. So no matter what you use the methods, AI or families, whatever, if they can come to screening, you are successful. So I think the thing is, we are come to the era of the personalized medicines, and not only for that, it's real time. That's why sometimes you miss 1 minute, maybe you miss your life. I'm not kidding. This is always, the metaphor of life. Screening is a mixture of the arts and science. It's not easy job. We are talking about science, but actually it's a reflect of the arts of the life. That's why we love the jargon of the Singapore about screening for life, but which is very, very difficult. So anyway, I enjoy all the countries. I mean, of course, our government from Deputy Director of HBA, and she proposed also very ambitious plan for all the cancer screening. I'm really very worried. Why? Because manpower, where is the manpower, clinical capacity, and where is the regional health manager like Singapore? They propose. This is very difficult to cover all the stakeholders. So that's why I believe, I personally feel very, think the meeting is very fruitful based on my summary of this presentation from yesterday until today. However, the 2 questions, my partners, we and I, we are fight. I cannot say fighting, but we always, work together for national policies from different angles, from different cases. So COVID, Taiwan also used priority by fecal concentration levels, try to help the government to inform those who has higher than the high level of the fecal concentrations. HAMO has already done much best to help them to reform. Even so, we can also see the impact, the consequence that we both use stage 3 and 4 cancers. We increased a little bit after 2023. I think every country is like this. Even in the UK, they take 2 or 3 years to compensate this pandemic death for cancer screening, not identify early stage. So that means, how can we learn from COVID-19? So that's why I give you a talk about the evidence-based precision and the metaverse. I want to share with you, everybody talk about AI, it's a technology, it's a digital things. No, AI is the conceptions to turn in our generation to the young generations. So don't always say, I don't know AI. You have to say, I want to learn AI. For everyone. Today, I believe everyone, I don't think in the classroom, everyone use not only ChatGPT, everyone use the large language models to ask, not only for science, not only for medical knowledge, for life. So why are we waiting for? That's why the COVID gives us lessons. So metaverse is not like the movies. Whenever I show the metaverse, everyone just laughing, say, "Oh, this is a movie. We have to wait 20 years, the 2 decades, 3 decades." But I want to ask the one question. Today we are talking about chips. Why is it so valuable? Think about it. So that's why I think I want to because I know time is very limited, but I say we have to advance the science. We cannot stand still. So that's why the thing is, how can we do? The only sense from all the countries we create is the data. Not only for one dimension, multimodal data. The text data, the video data, the imaging data, whatever, you need to multimodal data. That's why Korea, that's why Singapore, I think also Japan, they want to do the big data information systems. So even in Taiwan, Hammo already pointed out, we have so many registry data. But how to integrate? The integrate data is a big key, and this is very difficult. So the metaverse, the AI provide opportunity, the platform. Don't talk about technology, but talk about where is the platform. So Hongyi and I, we work together. We try to make these things, make this dream come true. So we have data science center, but still not good enough. So this is what I propose my feedback and also my partners assign me to answer such kind of questions, and I try my best. Thank you so much.
Yeah, thank you, Shu. I think from the Eastern philosophy of view in Japan, Korea, and Taiwan, most people they say to see and to believe. So using the AI technician or the large language model, we can show some cancer risk in vision. We can see, if you don't want to do the cancer screening at the right time, at the right time, maybe in the coming 5 years, the cancer risk will come out and giving a very red color, and everybody says, oh, something like that. So this might be very important to increase the health literacy among the northeast area people, because most our 3 countries the government provide many services to their people. So people, they rely on their people. They don't want to do it by themselves. But the health is herself responsibility, not the government, but because we have a very 100% coverage of national health insurance system. So Taiwan people, the health insurance cannot do. They say, everything, if I feel unhealthy, I go to see doctor. The cost can low. The health is not my responsibility, it's the government. So I think AI will increase some awareness or some risk awareness to our people. So I would assure you, we hope in the near future, using this kind of technology to promote or decrease the health of our people. Then the fertility rate will be increased, and cancer mortality will be stopped some little in the future. Yeah, take it forward. Because I asked so many people, there's the time to take this thing. So this is your time to raise questions, okay? The hour later, I will give the opportunity to our audience. I raise.
I have a question for Professor Chen. First of all, I many thanks for your good sharing about the experience. And I am very curious about the screening participation rate. As you mentioned, it's 42%, which really needs to be improved, as you mentioned. And I'm curious about, is there any possible reasons except minor issue that out of pocket from people really contributing to this rate? And for example, probably some cultural issue, because I think Japan people may be conservative, if any health belief in the cultural issue that related to this.
Yes, well, yeah, thank you for your question. It's a very important question and very difficult question to answer, because when we ask people, why don't you go to the cancer screening, they give us whole lots of reasons. They don't have money, they don't have time, they have something else to do, and they're afraid of cancer, and they would go to the doctor when they need to. Why don't you go to the doctor before they get sick? Well, a whole sorts of things. Maybe we have too good access to healthcare or medical care. So when they are sick, they can go to the doctor in a day. So that's why they don't appreciate the good chance of getting screened. Well, that's hidden reason. Nobody tells me that, but I'm guessing. Well, that might be the reason. But anyways, well, we need to educate the public that they may need the care before they get sick. And well, it's a very difficult. Well, there some people, some municipalities try to attract the resident attention by saying like the individualized letter of invitation, or like setting the deadline. So this is, well, it's like a time limited sale for products, so time limited screening program. So, well, it's effective in a way, but not much. So we need to think more, and we need to educate the public more. That's well, not the perfect answer, I know, but that's much as I can say.
Yeah, when you ask question, please identify yourself.
Hi, and thank you for providing us sharing the valuable information yesterday and today. I'm from Health Promotion Administration, one of the member. I'm Jai. And I think following the questions, I just want to answer about, do you think there are more behind the knowledge, the lack of knowledge or lack of, like you say, like Dr. Dashi said, maybe because they have they take the CRC screening at the workplace and they don't want to bother others, so they refuse to go to the hospital to check the positive result again. So I think my question would be like, do you think it's valuable to look more into the barriers behind these problems and to create the tailored strategies to address these problems? And also, I would like to know, do you think it's necessary and possible to create a common Asia strategy? Because as you know, I think Asian people has a very specific characteristic comparing with Western people. And I think now we follow more about Western structure. So I would like to know if we're going to create more tailored Asian strategies. Thank you.
You know, the best person I suppose is yeah. You mentioned about the behavior, the thoughts in the future based on the behaviors.
Singapore.
Yeah. This is that question she asked.
Well, thank you. I'm not sure if I'm the best person, but at least we can share the Singapore story. Yes, we do collect data, both quantitative data as well as qualitative data, because every time we find the screening rates, similar to Japan, our rates are pretty low, particularly for cancer screening. So we always go to find out what the reasons are, and as Prof. Higashi mentioned, they do tell us certain things, but we know there are a lot more hidden reasons behind what they are telling us. So in my presentation yesterday, I shared a bit about the barriers, misconceptions, and myths. So what we do is one set of area we look at is a quantitative survey, which just tells us, okay, we have like list of reasons which we think of and we give them, and they can just give us a number based on that. 70% said so, 80% said this, and all that. But we also go into probe to finding out specifically what this actually means. So when someone tells us, I feel fine, I'm healthy, I don't need to screen, what are they actually telling when they say that? When they say, I have a fear of screening results, what do they mean by that? So that's when we do a lot of these kind of qualitative insights. We do focus group discussions, we do IDIs, in-depth interviews, we do talk to people, and it's not just the residents or those who are participating. We also talk to multiple stakeholders. We talk to the providers, the GPs, we talk to hospital people, we talk to community people, we even talk to lab folks and all. So there could be certain areas which is not seen, is not known, is not communicated. Then bringing many different parties into this discussion then helps us to identify some of these smaller gaps or certain challenges, and that will help to bridge some of these and address certain issues. One area I think you were asking about whether it is time to bring in an Asia or Asia-Pacific kind of strategy. I think this is one such setting. Definitely we all share a certain cultural commonality, I would say. One common thing which I've seen or I've read from basic literature is as Asians we have this component about family and filial piety and so on and so forth. So we use that in our campaigns a lot. So we always say, when we tell you go screen for yourself, they don't bother. So what we tell them is you screen for your loved ones, so that they have a peace of mind. You don't become a burden to them because of your disease. So you screen early, you detect early, it is actually managed early, which means you're not becoming a burden for them in later on life. So that is a different angle. Instead of saying me and I, if I say you don't go do it for your family, it gives a very different perspective, and people are then open. Versus if we keep telling them to go, mostly, even in Asian culture, I mean, I'm not sure about all cultures, but pretty much in Singapore, they will tell us all three ethnic groups, Indians, Malays, as well as our Chinese majority, all of them say, it is just me, I don't matter. If it's my family, if it's my parents, if it's my children, okay, oh, I didn't realize that actually affects them. So they don't mind when they come forward. So those are things which definitely can be done. But having said that, I still think that each country will have to have certain level of customization. Because what applies to the, I dare say, Singaporean Chinese may not necessarily apply to the Taiwanese Chinese. There are certain subtle differences. We have our own systems, healthcare systems, we have our own ideologies, we have a very different political system, a very different political commitment. So I think we also have to then customize and adopt based on that. But I think certain basic principles can definitely be laid. And this kind of Asia-Pacific sessions can come to a consensus and we can agree on something. That's just my 2 cents in that.
So following this issue, I would like to share with you our attempt in National Taiwan University College of Medicine. So awareness about colorectal cancer screening is very important, not only by the public but also by the doctor. Even now, some doctor may persuade people no need to go for colonoscopy even if fit in poverty, just because patients claim that he or she has hemorrhoid. So what we have done in the past 4 to 5 years is we have a class lecture specific for colorectal cancer screening in the 5th grade of medical student in the College of Medicine. Usually the content of the lecture taught in the classroom in medical school probably has a 5 to 10 year gap compared with the most day-to-day living. So even we look at the Bible textbook of internal medicine, the Harrison internal medicine, only 1 or 2 pages were talking about colorectal cancer screening. So given that colorectal cancer is one of the most common cancer, not only in Taiwan but also in other Asian countries, I think we have to take action. And about 10 years ago, we have conducted a survey study in the Asia Pacific, and what we have seen is doctors' advice is the strongest factor to motivate people to go for treatment. So this is very, very important. So the first thing is that we have to teach our doctors that we can expect the improvement in awareness of the public. So there is a old saying that people's mind is like parachute. It never works if it is not open. So I think this is very important that we should educate our doctor. So colorectal cancer screening is not only the business of GI doctor or family doctor. Diabetes patient has a high risk of colorectal cancer. Hypertensive patient, people with coronary heart disease have sure common risk factor with colorectal cancer. So I think we should teach all the doctors with different specialty about the importance of colorectal cancer screening.
So indeed, this is a very good question about cultural specific, the personal invitation to screening. That's why I asked Alika to answer, because you sure. But of course, we learn from Professor O, talking about health literacy and also shared decision making. But I can feedback to you for 2 or 3 decades. Hong Yi and I, we use so many behavior models, health belief models, theory of reason, action model, every model to identify the reason why they don't come to screening. So we know, we have a Western, always claim this is Western culture and the Oriental cultures. So I believe one sense very important from Professor Ikashi. It's talking about the shared decision making. Shared decision is not superficial format. I like your terminology, superficial. Because when you do the shared decision making, it's not only for patients, not only for your client, but for families, for your peer group. You can have a reinforced learning. I use the AI language because this is actually the AI wants to. Why the Korea have playing chess, winning, with the AI compared with the human being brain. This is because they have a play, they have an interactive. They see what you say, then the humor will react to your question with different angles. So that's so important for our job is to increase the health literacy. This is Professor Cho's. Regardless of method you use, whenever you can increase health literacy, then you win. Whatever. Don't forget about metaverse, AI, precision. Forget about anything. Talking about health literacy. Did you have health literacy for swimming? No. If you don't have this, and if you even good doctors, even good professors, even good decision makers, it's still useless. Okay? So I think this is a very good question. You can keep discussing. No optimal answers so far because culture is different. But you need to keep this in mind. Thank you.
Very good question. Yeah, I think the C2PD using the good data, high quality data, can give our resident a good idea and a good concept to share decision with the doctor. And they will. And I think the time difference, maybe the final question I give the Professor David. Yeah.
National Health Research Institute, Health Policy Research Center. So I have a quick question for Dr. Higashi. In your future direction, you mentioned about some new mechanism. It's called mini puppets. Okay, you talking about some jury duties to some residents, and they can decide who is guilty or not guilty. Okay, so because we all know people get lazy and stop when there's no police, when there's no CCTV. So this kind of peer pressure or some surveillance in the neighborhood can be a very important thing, which also echoes to all the experts mentioned about maybe we need some more, something more than just raise awareness, more than just education or provide incentives. Maybe we can do something more pushy. So I'm very curious about your idea. So how exactly this will work? Can you just explain a little bit?
Yes, thank you for your question. I need to, I should clarify a little bit more. I'm not telling getting people together and decide which one is guilty or not, getting screened or not. It's just the group of people invited randomly from the society, the community society, and then discuss how they can invite more effectively the community members to get screened. It's not like a policing kind of thing. It's like asking and discussing and reaching the conclusion, both the solution for the problem from the lay person's perspective, because they're trying to influence the behavior of lay person. So, well, it's a new method, and well, we are kind of losing actually in Japan, losing the trust of traditional democracy, of getting the elite people to decide everything, professional politicians to guide the country. Well, we are losing the trust in that, so we need to listen more to the ordinary people. So that's one of the movement that we are trying to think about. And we haven't done it yet, but it's one idea to listen to the author.
Okay. Okay. Due to the time constraint, I need to end the roundtable discussion. So I will, with our co-chair, Josie will take our 5 excellent speakers for your excellent sharing the experience and discussion, and also response question from the floor. And also thank you all the audience in this room to give us a very good question. Thank you. We are ending the point. Thank you.